Good afternoon, everyone. Thank you for joining us today. Jonathan will be talking about Fund Your Mission. This is part of our CEO CFO webinar series. Before the recording started, we were just tossing around the idea of maybe moving forward, doing shorter webinars and maybe having more on-demand options rather than live recordings. So if you're watching this recording, please send me your feedback. We would love to hear from you. As we move forward, if you have any questions at all, please feel free to unmute your lines, put something in the chat, or if you're watching this recording, please feel free to email me with any questions you might have. With that said, Jonathan, I'll turn it over to you.
Thanks, Laura. Excited to present on this topic today. Now, when we talk about the transition and really the practical steps moving from volume to value, it's very much founded under the concept that in today's times, finance is having a direct impact on quality, and quality is starting to have a direct impact on finances. Now, as critical access hospitals, oftentimes we're exempt from many of the requirements that are established for our OPPS, IPPS type hospitals, similar to the fact that we don't have readmission penalties, we don't have hack penalties, we don't have all of those things tied back to those organizations. But nonetheless, even though we don't have those specific things that is really moving more towards value, we have to start to realize that the broader industry as a whole is moving more towards value-based care. We've seen the advent of ACOs, we've seen population-based initiatives, we've seen PCMH in clinics. We've seen all of these additional ways that we're starting to move from volume to value. Now, when we think about it to that degree and we start to look at moving from volume to value, what we cannot do is jump straight from a fee-for-service, volume-based reimbursement methodology to very much a value-based reimbursement methodology. There's a lot of practical steps that we have to go through, and we have to start to operationalize these components if we're looking at transitioning between those two different areas. Again, if we were to try to jump straight from volume to value without making those operational steps and operational changes, we could be left with a significant cost structure or an unsustainable financial position going forward. So we have to do our due diligence and ensure that we are positioned effectively and positioned to push ourselves going forward. Now, when we talk about the rural environment, again, and I always kind of start with this as a conceptual framework, we always have to remember that the rural environment is different than many of our urban counterparts. We experience many barriers that are not inherent in other parts of the industry. Oftentimes, we have limitation to specialty services. We're sharing the same providers. We have one provider that may work in the emergency room, also in the clinic, and also do inpatient coverage. We have to realize that as we start to move from that volume to value, we have to fully evaluate the operational performance and our configuration in the current environment so that we can ensure that as we are starting to move forward, we position ourselves effectively going forward. Now, again, 1 in 5 Americans do live in rural communities. So there is a significant portion of the patient population out there that does live in many of these rural communities that are served by these rural providers. Now, what are some of those barriers? Again, an extremely fragmented market. Now, when we talk about going towards value-based care and we talk about the current environment that we're in, oftentimes many of our critical access hospitals or rural health clinics or rural providers, they do not provide the full complement of services that we see in urban facilities. Again, you're not doing all the surgical services. You don't have specialty care units on the inpatient side. Oftentimes, you're not running distinct ICU. You're not doing all of those additional services that allows you to fully integrate and control the health outcomes and cost exposure for a specific patient population. So when we start looking at that and we start looking at population-based and value-based care, we have to come into the realization that significant portions of the cost attributed to our patient population oftentimes will remain outside of our control as an organization. We also have to realize that a lot of times there are a lot of complex, arcane, and fluid regulatory environment that we have to encounter as we continue going forward. I'm sure all of you remember the Consolidated Appropriations Act of 2021 that fundamentally changed the RHC reimbursements going forward. In addition to that, we've also seen administrative changes relative to the COD distance requirements and different things that are considered primary versus secondary roads. We continue to see changes in the healthcare industry, and we have to ensure that we continue to evaluate those and remain current on those changes so that we can continue to push ourselves going forward. In addition to that, a lot of the things from a value based approach require either additional staff or additional resources to effectively move in that direction. Again, if we're not positioning ourselves appropriately, that cost structure can significantly or materially impact the ability to remain financially solvent going forward. So, again, we want to continue to factor those things and how we continue to position ourselves. Now, when we look at opportunities for organizations, particularly for our critical access hospitals, oftentimes you have more opportunities than you see in many of those urban counterparts. Again, you can look at service optimization, you can look at delivery optimization, you can look at the expansion of services. One thing we have to take into account is as we start to evaluate what services we may want to add down the road, we have to ensure that we do the appropriate market analysis to ensure that we can sustain those services going forward. We cannot continue to operate in an environment where just because we can bring on a certain provider means that we should bring that provider and integrate them into our operations. We have to continue to evaluate what can our market support and what can we sustain going forward. Now, because Medicare and in many states Medicaid as critical access hospitals, the best we can do for our core services is cost-based reimbursement. The only ability that we have to actually make profit is our non-cost-based payer mix. These are the things that we have to evaluate, and these are the things that we have to drive down and dilute our cost per unit of service as we start to drive and look to create profit for our organization. Now, what is the current landscape? Again, we've exited the COVID pandemic. Many of us are starting to get back to a normalized environment, or at least a post-COVID normalized environment. However, over the past few years, all of us have experienced material impacts to the ability to continue operationalizing and delivering effective primary and secondary and inpatient care and so forth. We've all had revenue cycle issues. We've all had service disruptions, policy changes, outmigration, and so forth. What we've realized also as we've continued to go through this environment is we've seen a stagnation of our reimbursements, and we continue to see our costs outpace our reimbursements going forward. What we have to realize is as we continue to see inflation outpacing revenue gains under our critical access hospitals, we are going to continue to see a worsening or a degrading of our financial position as critical access hospitals. So again, we have to take that proactive step going forward, and we have to look at opportunities as to how we can improve our performance. Again, we cannot jump straight from a volume-based reimbursement methodology, which critical access hospitals are very much volume-based, to a straight value-based reimbursement methodology. We will only put ourselves in a negative position. Now, what is the reason for some of this? As a critical access hospital or a rural health clinic, a significant portion of our cost is fixed cost. Again, when we think of fixed versus variable costs, upwards of 90% of our cost is fixed as a critical access hospital. Now, what that means is we can really only effectuate change on 10% of our expenses in any given year as a critical access hospital. The reason why I emphasize this and the reason why we're starting to look at this is because as a critical access hospital, we cannot cut our way to success as a critical access hospital. Now, when I say that, there is a caveat to that. Again, if we're spending unnecessarily or we have not created efficiencies or we have not looked at optimizing our environment, yes, we can reduce some unnecessary administrative cost or unnecessary overhead cost. But as a critical access hospital, we will eventually reach a point where we can no longer cut cost because we have what is our minimum staffing standards and our minimum operational expenses to continue to remain viable going forward. And ultimately, it will get to a point if we continue to cut services back and cut cost, we will ultimately have to decide whether or not we want to continue offering that service or we want to discontinue that service going forward. Now, for some of our programs, our emergency department, diagnostic imaging, lab, those core critical access hospital services, we cannot cut these going forward and remain as a critical access hospital. Now, when we look at it to that degree and we look at the fact that we cannot cut our way to success, what is oftentimes the solver for critical access hospitals? Now, because we are reimbursed as a critical access hospital where cost is divided roughly by visits or charge structure to ultimately determine a ratio of cost to charges, what we can't do is we can't again cut our way to success. Now, because volume has that direct impact on the reimbursements we receive by nature of either rural health clinics with the actual visits itself or the charge structure as a critical access hospital, as we increase our volume as a critical access hospital, we are generally going to dilute down that cost per unit of service and will actually put ourselves in a profitable position. Now, because there is that direct correlation between cost, visits, or charges as a critical access hospital and reimbursements, as we start to pull expenses out of our facility, again, that cost per unit of service is going to come down. On the inverse of that, as we start to see a decline in our volumes within a critical access hospital, we are going to see the cost per unit of service going up. So, as a critical access hospital, in some capacity, we are insulated if we want to start moving more towards these value based initiatives. Because if we're able to improve patient outcomes and start focusing on those initiatives, as we pull out some of that volume, we will see an increase in our Medicare reimbursement rates. Now, again, this doesn't really help us if we're in an ACO because, again, the cost per unit of service is going to increase. So the total spend will stay the same for the patient population. But nonetheless, in a normalized environment, it will insulate us if we want to start looking at some of those population based initiatives. But again, if we're looking at certain services and we're trying to pull volume out of our facility, that does make us a more costly provider. On the inverse of that, if we start driving more volume to our critical access hospital, we will actually make ourselves a less costly provider when comparing us to other area providers offering the same services. So it's very hard to transition solely from a volume to value based initiative because of the direct correlation, again, to the cost and the reimbursements received as a critical access hospital. Now, whenever we open as a critical access hospital, just opening our doors, we automatically start in a loss position. As we continue to increase volume, we will slowly reach an inflection point to where we eventually pass into a profitable position. Now, again, depending upon our cost mix and the services we're providing and the proportion of those services across the different payers will ultimately dictate when we reach that actual profitable position. Now, one thing I do want to emphasize just on our net service patient revenue. So again, those core services that we provide, carve out the 340B, carve out any tax revenue you get, carve out any grants or donations. If we're just looking at the actual net patient revenue that we receive, the only way we can make a profit as a critical access hospital is to reach a point where we drive down our cost per unit of service for our cost-based payers to less than what we're getting from commercial. So long as we're getting more money from Medicare and Medicaid, if you're cost based, than we're receiving from commercial, we will have to receive additional non operating revenue or additional incremental revenue to offset that differential between what we're getting from Medicare and commercial. So, again, we really want to start looking at our cost per unit of service as a critical access hospital and comparing that back to our commercial rates. This is something that we should be doing now, or if we're considering at moving more towards a value-based program, is evaluating that cost per unit of service relative to our commercial payer mix. We do not want to be put upside down. Now, what really started transitioning or pushing the drive towards population-based care and volume to value discussions and all of those? Now, it really came out as a part of the IHI, the triple aim. Now, I realize if you look in today's times, it's also expanded to the quadruple aim. But for the purposes of today, I'm going to talk predominantly about the triple aim. And the triple aim focuses on three major components. It talks about population health, talks about experience of care, and it talks about the per capita cost. Now, the overall goal of the triple aim is to improve patient outcomes in a financially advantageous or beneficial way that does not continue to increase the cost of care. The goal is also to increase the focus on individuals and families, increase cost control, and really start to look at the integration of systems and platforms across the broader healthcare landscape. Again, remove some of the siloing, or remove some of the duplication, remove some of the unnecessary efforts that continues to permeate throughout the environment. Now, what are the different reimbursement models? Now, again, there's different types of reimbursement models that we can partake in. all of them are still very much precipitated or driven by a fee-for-service methodology. Again, we may have at-risk models, we may have some other type of value-based care, except for a couple of the value-based initiatives, most of them are still fee-for-service type and reimbursement. Now, under a fee-for-service methodology, you will receive a reimbursement rate based on the actual number of services that you bill and provide. There are several pros and cons for each of the different reimbursement and payment methodologies. There is no one size fits all. What works for one organization may not work for another organization. Even though there are pros and cons for each scenario, you have to evaluate what works for you and what you can operationalize going forward. Now, what are some of the pros of a fee for service reimbursement methodology? It encourages, incentivizes the delivery of care and maximizing patient visits. It offers greater flexibility. You oftentimes can get in to see providers more quickly, and providers are held directly accountable for the services that they provide. I'm sure all of you have seen in current times insurance companies pushing back because they say something doesn't meet minimum requirements or it's not medically necessary or so forth. So again, we have to justify the services that we're providing in order to receive compensation for those services. What are some of the cons? Again, it does not push efficient care relative to patient outcomes. Again, if you're able to schedule a patient for a bunch of services, you're going to schedule that patient for those services. It lacks care coordination, again, because each provider is directly reimbursed for the services that they themselves provide. It very much drives that siloing that we see within the healthcare environment. It also leads to a much more complicated system that is probably otherwise needed in a healthcare landscape. Again, we are all driven towards CPT and revenue, and we're all driven towards the services that we're actually providing. The next area really jumps into value-based care. Now, when we talk about value-based care, there's different levels of value-based care relative to the exposure that you want to come forth and realize as an organization. And those four main types of value-based care is shared risk, bundles, global capitation, and shared savings. Now, each one of these, again, has inherent levels of risk as to the downside and upside exposure for each organization and how much they may be able to get as an organization going forward. Now, the first one is shared risk. Now, in a shared risk environment, providers are penalized for failure to achieve a set cost structure for a specific population. Again, the goal of a shared risk model is to force participants to achieve those established cost levels. And if they don't, they're going to actually experience financial penalties for failure to achieve that set cost structure. Now, think of this kind of like your next gen ACO type model. Again, when you had the benefit of that environment, if your cost structure surpassed what was agreed upon, you had risk relative to how much additional revenue you could get if your cost structure went up for the attributed patient population. Now, what are some of the pros of a shared risk environment? It could lead to cost efficient and high quality care to patients. Providers have a vested interest in the cost of care and outcomes. It may reduce unnecessary services, and it focuses more on population health management. What are some of the cons? Again, it creates an unsustainable environment that could be outside the control of the provider. As we saw through the COVID pandemic, we saw significant increases in cost. We saw organizations have to bring in traveler nurses, locums. We saw providers having to shut down services. We've seen all of these additional things that caused a significant increase to the cost of care across the healthcare landscape. Without some type of retitration, this could put us in an unsustainable environment going forward. It also creates an environment where providers are less likely to refer somebody out of network. Again, if you have a patient that needs a high costing procedure, you're not going to send them out of network because that's going to come at a direct attributed loss to your organization. And again, it could also cause our providers to change focus from the delivery of care to more of a cost containment type environment. So again, pros and cons on both sides. Bundles. I'm sure everybody is aware of the bundles. We've seen them popping up with Medicare. We've had total hips, total knees. We've seen some cardiac type services. We've seen all of these pop up as a bundle type payment. Now, under a bundle type payment, you're receiving reimbursement for providing a certain service, and that usually includes the pre-op and the post-op type services. As you continue to work forward, again, This creates an environment where you are going to get a fixed reimbursement for providing that service going forward. Now, what are some of the pros and cons of that environment? Again, it improves care coordination. Because you have that limited cost structure or that reimbursement, you're going to want to partner with other organizations that are able to meet those care requirements. It can offer greater flexibility because you are receiving a fixed payment and you're controlling the entire episodic care for that patient. You're able to place that patient to where they can actually receive services. It can lead to the effective management of services. Again, all of these are pros in the bundling aspect of reimbursement. Now, what are some of the cons of those services? Again, some of the cons are they're not always clearly defined. Sometimes organizations may push a patient to a specific provider because of the cost associated with that care, not necessarily the provider that would lead to the best outcomes for that patient in that environment. Again, it does not create specific incentives to reduce unnecessary episodes. It does require or force organizations to maybe redirect care to less costly environments, but you're still reimbursed as an entity for providing that service as a whole. So again, if somebody needs a total knee replacement, they may jump straight towards that total knee replacement without doing other type of interventional type services, whether it's physical therapy or other things to that degree. And also, high risk patients may not receive care due to the potential exposure for a provider. If you have a patient with multiple comorbidities that may need long term rehab services after, you may defer or delay care for that patient and not do that total knee replacement because of the adverse cost and the outcomes potentially attributed to that patient going forward. Global capitation. Now, under global capitation, this is an environment where organizations receive a fixed payment for a specific population. I'm sure all of you have heard of the Maryland model, and we've also had the Pennsylvania model, which has started to pop up. Now, in these environments, it creates a process where organizations receive that fixed reimbursement for that specific population over that period of time. Now, again, same with the similar ones, always pros and cons of each of these additional areas. It can increase the direct alignment between the provider and patient. Again, you want to improve outcomes. It can increase flexibility entities have relative to provider payment models. If providers have better leverage and capitation when negotiating with payers. And it also focuses more on preventative services instead of truly those emergent or high risk type services. What are the cons? Again, similar to shared risk and other types. Patients may see a delay in receiving certain services. Patients with higher costs in certain pre-existing conditions may be excluded from participating in that methodology. And the relative risk to an organization can be high if you're unable to provide the necessary services. In addition to that, what we've also seen in some of the states that have gone in this methodology is it's very much been signed up and based on what your cost and expense structure is for that patient population at the time you sign up. So if your organization was very efficient and very effective, and you are very much operating at the top of your licensing capacity, and you have a very low cost structure per unit of service, you could actually be penalized in some of these models because you're not going to be able to control this cost as much as an organization that is either unnecessarily spent or has a significant high cost structure. In addition to that, they haven't really addressed the capital requirements associated with a global capitation. Again, many of our hospitals are 30, 40, 50 years old. Replacing a hospital in today's times has a high cost. And how are we going to reimburse our organizations or cover the cost of actually rebuilding that facility if we have a fixed budget that does not include the cost of capital going forward? Again, we have to take all these things into account. The last area is really around shared savings. Now, most people that have jumped into value-based care have jumped into the shared savings types approach. And under this methodology, under a shared savings model, as you're able to reduce the cost of care for that patient population, you're able to share in the savings back to either Medicare or whoever you're able to negotiate that relationship with. Now, what are some of the pros and cons of shared savings? Again, it may provide cost-efficient and high-quality care. Providers are incentivized, again, to reduce the cost so that you can get those shared savings. It helps to diversify revenue streams, again, moves you away from that straight fee for service and gives you some of that revenue on the back end. And it does create a focus on population health management. What are the cons of a shared savings type model? Again, there are significant costs implementing this program. It creates an environment where providers are less likely to refer out of network. Again, organizations are more concerned with keeping that expense and that revenue inside the system in the ACO than letting patients go outside of that. Again, it rewards high cost providers that can manage expenses instead of providers that already provide value based care. And all of these programs come with significant administrative burden in trying to implement and maintain these things going forward. Next, what we're going to talk about is some different ways that we can start to implement value based care. Now, when we look at going towards value based care, this is something that is an organizational change. It's not something that we can actually just implement tomorrow. We have to ensure that our staff are on board. We have to ensure that we're financially established and able to sustain the transition. And we have to ensure that our population, our patient population, is able to move in that direction also. So, what are some of those success factors? Again, culture and leadership. We have to ensure that our leadership and our culture within our organization is set to move more towards value based care. It comes with a comprehensive understanding of what value based care is and how we will start to transition towards that approach. If we're looking at moving in that direction, I would definitely have a business plan and a strategic plan and an operational document that kind of draws out how we plan to transition from the one environment to the other. Provider strategy. Again, providers in today's environment very much drives and dictates what levels of reimbursement we receive and what services that we are providing. When we talk about provider strategy, if we are in an environment today, for instance, let's say we pay all of our providers a salary and then a bonus based on work RVUs. How are we going to get our providers to want to transition towards value-based care if all of their compensation or a majority of their compensation is tied to work RVUs and the number of services that they're providing? Again, on the inverse of that, let's say we predominantly pay our providers, let's say we're talking about a rural health clinic, and we predominantly pay our providers a fixed salary with some quality incentives. How are we going to get our providers to increase volume if there is not any incentive for them to increase that volume going forward? So again, we have to ensure that we evaluate our provider structure and we have established it in a way that as we continue to transition towards these alternative models, our providers are also moving in that direction. Operations, technologies, and partnerships. Again, we have to continue to evaluate the type of partnerships, the technology, and the environment we're in. Can we actually operationalize a transition from volume to value? Do we have enough support staff? Do we have care managers? Do we have discharge planners? Do we have all of the people that can focus on value-based care? In addition to that, do we have the staff that can actually encompass the administrative burden with transitioning towards value-based care? Does the technology we have in place at our facility, do we have the appropriate EHR to actually extract all of the data necessary to start to transition more towards value-based care? We must evaluate what is actually required to transition in that direction before we incur the cost associated with transitioning and moving in that direction. We also have to gain a better understanding of risk-based contracting expertise. Now, I've been to several critical access hospitals across the country, and oftentimes, at best case scenario, they're evaluating their contracts once a year. I've been to many organizations where they haven't evaluated their contracts in several years. If we are going to look at going towards some type of value-based care, we have to ensure that we have the expertise to start evaluating and determining our contracts based on risk-based contracting. Again, it's not something we have to employ directly, but we need to have some type of access to that expertise going forward. Data mining. Now, this I often say is the most overlooked area relative to our critical access hospitals and rural health clinics. One of the most valuable services or resources we have is the data within our facility. Again, how we leverage that data going forward can really start to position ourselves to make operational decisions more effectively. We have to start pulling data. We have to evaluate the services that are being received at our facility, and we have to start to look at those things going forward. We can start doing things like mapping our patient populations. We can start looking at the proximity of patients to our facilities. We can start looking at bell curves as to the type of services they're receiving in the different departments. one of the most valuable reports, at least for me when I used to be a CFO at a hospital, was really the revenue detail report. I would constantly pull the revenue detail report by the different departments, and I would look at it across the different financial classes. Again, I wanted to look at what were we charging for? What were the payers? What were the distributed services? Did we see general services across the different financial classes? Again, all of these are additional things that we have to start to look at. Even if we're not transitioning to value-based care, these are the type of things that we should be looking at as part of our day-to-day operations and gaining a better understanding as to our payer mix and the services being received at our facility. And then the last is really around financial literacy and modeling. Anytime we're looking at potentially an alternative reimbursement methodology or model, we have to do financial modeling and understand how we will be reimbursed and compensated going forward. Now, recently we saw the Rural Emergency Hospital come out, and several organizations are looking at potentially doing that. But again, we have to ensure that we can transition towards that or any other model and how we are going to get reimbursed under that model. In addition to that, we also have to ensure that we have adequate cash reserves if we transition to one of these other models. If we go to a shared savings type model, again, we're going to see a reduction in revenue throughout the year, which is going to impact cash flow. We may get those shared savings on the back end, or we may get a reconciliation of our cost report that leads to reimbursement on the back end. But again, that will impact our cash flow going forward. We have to ensure that we are positioned effectively going forward. Now, whenever we talk about these type models, it's important to know that this very much drives, I would say, the convergence of quality and finance as we're looking at those additional areas. Now, again, when we look at that convergence, it's important to realize how will this impact the ability to deliver care and what will it do financially. So if we are looking at going potentially towards one of these value-based models, this is a project that I would really look at doing combined with a CFO and a CNO, or a CFO and a COO, to really start to map out what will this mean organizationally. Again, oftentimes CFOs do not have the clinical knowledge to understand the delivery of care, the placement of staff, the services, the levels, and all of those additional things. On the inverse of that, oftentimes our CNOs do not have the financial acumen to understand the financial impacts of all of these changes to service delivery and so forth. Again, have them partner together if we're looking at any of these value-based initiatives. Now, what are some of the other operational considerations that we can take into account when we're looking at value-based care? Again, we have to start looking at clinically integrated networks. We have to look at the operational functions, the organizational functions, and how we can start to look at these things going forward. We have to focus on care coordination, clinical accountability, proactive care, team-based care. All of these are different operational ways that we can start to move towards value-based care. On the organizational components, again, we have to look at clinical leadership, information technology, financial position, fund flows, performance improvement. This is not something that we can just jump into tomorrow. We have to understand the nuances and the ramifications on our organization. Now, there are ways that we can start to dabble in value-based care. We can negotiate a PMPM with commercial payers. We can start to focus on PCMH. We can start to focus on other ways to actually move us towards value-based care. But again, have an understanding of those directions and how we can move into that direction. Some of the other operational considerations, again, the internal referral processes, integrated care initiatives, and so forth. We want to start looking at these areas on the internal referral processes to really start to remove the unnecessary administrative burden. Many of you have probably heard the term interoperability relative to IT systems and EHRs. We have to start to address IT systems. We have to start to create interfaces to share information and to start to move information relative to patient care more freely across the healthcare entity. Again, we want to look at these things going forward. Integrated care initiatives, again, they must be evidence-based. We have to expand access to care. We also have to evaluate the integration of all services into that healthcare environment. Now, when we're in a rural environment and we only provide certain services, again, that oftentimes can be difficult. But look, even in today's environment, one of the areas that continues to have a significant amount of area of concern is mental health and behavioral health services within rural communities. Have we looked at starting to integrate behavioral health and mental health into our broader landscape? Have we integrated primary care into our hospital operations and made that a part of our total landscape? Again, we have to start looking at all of the service need of our patient population and all of the services that they may require, and then start reaching out to other organizations. We do not always have to provide these services directly ourselves, but we have to ensure that we have the availability of resources in the event that our patient population needs access to those services. Now, the next couple areas, again, I'm not going to go through each one of these different things, but care management services. Now, care management services, I would say, is one of the opportunities where we can quickly start to jump into certain type of value-based care. And there's a whole bunch of them. You have TCM, which is transitional care. You have chronic care management, CCM. You have COCM. You have BHI. You have an entire health alphabet soup of the different types of care management services. These are ways that they can start to focus on how we can start to integrate services and really start to focus on patient outcomes as a way to start to move towards value-based care. Again, this is less concerned with the direct services that are being provided, and it focuses more on the outcomes and the coordination across different providers in trying to meet the different requirements of those care management services. Now, when we talk about the care management services, these are also ways that we can get reimbursed, whether we're in a rural health clinic, whether we're operating a clinic. It's different ways that we can get reimbursed for the services that we're providing. Again, it reimburses us to continue to stay involved with those patients and to start focusing on healthcare outcomes and the betterment of those patients over a longitudinal period, as opposed to just focusing on the short burst of CCM type or CPT type visits. The last area is really around PCMH. Now, I'm not going to say that we have to go out and become a PCMH certified program, but we can lend upon many of the concepts that are pushed as a part of the PCMH. We can look at what it means to be a PCMH type entity and start to institute many of those services and things into our organization as a way to drive patient outcomes. Now, again, whenever we look at any of these value-based initiatives, you can operationalize these different components without going through truly a certification process. But nonetheless, this is something, again, when we think about primary care, this is an area we can start to look at as a way to start to transition from that volume to value-based care. How can we start moving in that direction? And how can we start working towards dealing with our patients and start focusing on those health outcomes going forward? Again, very much focusing on a value-based strategy. Now, I know I went through a lot of this information pretty quickly. And again, it was very much just to lay the foundation and start the conversations around transitioning from volume to value-based care. Again, to emphasize, this is not something that I would suggest you just jump into tomorrow and say, we are going to now forward be a value-based provider and not focus on the volume side. It is something that is going to take some time to actually transition from one to the other. And as we continue to look forward, we want to ensure that we position ourselves effectively, again, making sure we do our financial due diligence to make sure we have adequate resources and to make sure that we are positioned effectively to move more towards that value-based care. So I'm going to pause now to see if there's maybe any questions I can answer.
Jonathan, I'm not seeing anything come through the chat. We have a small group today, so if you have any questions, feel free to unmute your line. All right. Well, if you're watching this recording and if you have any questions, please reach out. I'll be happy to put you in touch with Jonathan. With that said, Jonathan, thank you so much for your time and thank you so much for the presentation.
Thank you very much. Everybody, I hope you have a great day.